Welcome everybody to our third webinar for COVID-19 and perinatal mental health services. My name is Liz Cullen. I'm Head of Clinical Programme for Maternity and Perinatal Mental Health for Hampshire and Thames Valley, and also working on the COVID-19 maternity cell with the regional team and Kent, Surrey, Sussex. Jenny, do you want to just introduce yourself a second?
Yeah, my name's Jenny Walsh and I am the Clinical Lead for Perinatal Mental Health for Hampshire, Thames Valley.
Super. Can we have the next slide, please, Ryland? So just some housekeeping. So if we could just ask everybody to put yourselves on mute and also to switch your camera off. It just helps with the quality of the camera of those that are speaking at the time. Obviously, don't forget to unmute yourself if you want to ask a question. It is an interactive session, so please do ask questions. Feel free to also comment in the chat box. And we'll make this as interactive as possible. The webinar is being recorded and the link will be shared afterwards for those that also couldn't join this morning. Next slide, please. So just there's your toolbar. Hopefully we're all getting used to using Teams now, but there's your toolbar in terms of how to switch your camera on and off, to mute and unmute. And you won't need to share your files today. We'll be doing that for the speakers. Next slide, please. The conversation box, please keep the chat open. Feel free to put in any comments, any questions. If there's a question there already in the chat box that you are particularly interested in, just give a thumbs up emoji and we'll look at those throughout the webinar to make sure that we discuss and pick up the most pertinent questions as we go through. Please obviously feel free to also to unmute yourself and ask the questions verbally as well. Next slide, please. So we've got quite a busy agenda for this morning. We will be finished by 11:30, but various different speakers, and we'll introduce them as we come to them throughout the morning. But we're going to kick off with a national regional update from Jenny. So I'll hand over to Jenny now.
Okay, hello everyone. I just want to wish that you're all okay at the moment. I suppose we're getting into the new normal now, but that in itself is flagging up a lot of issues, and I hope some of those we will be covering for you today. You'll notice I'm wearing yellow because it was International Day of the Midwife yesterday, and yellow was the colour. And we're also in Maternal Mental Health Awareness Week, and today is World Mental Health Awareness Day. So a little bit more of those two things later on. So the first slide has been lifted from a webinar that I attended for the national perinatal team last week. And this is the sort of ways that they're hoping that the clinical networks are supporting all of you out there today. So I just wanted you to see that. You're just skimming through. I don't want to labour any of these points. You will get the slides afterwards and you can go through them. But one of the second to last bullet point you'll notice is about redeployment, which I think the national team are quite concerned about. And those of you in the specialist services will know that we did a quick shout out and a survey about that. So thank you to all of you for your responses, and that's gone back up to the national team. But do get in touch with us if you have any issues with that. And we're also very keen to share any examples of best practice. We're all having to learn how to work very differently and very quickly. So if you found a quick fix, whether that's around how you keep a sense of team when everyone's working remotely, how you make sure you're checking in on staff wellbeing, right through to some of the virtual groups that have been springing up. And I know we've got another lovely example of that later that Dawn's going to tell us about. Okay, next slide, please. Thank you. And these are some topics that the national team were hoping that you guys out there in the clinical teams would be considering. And I know from my discussions with some of you and from things that have come up on the webinar that these are things that everybody is considering. But just as a bit of a prompt for people, looking at how COVID might exacerbate some mental health issues for people, having to manage more complex people in the community because women might not want to be admitted at the moment because people are quite frightened about going to hospital. Excuse me. The impact on training, and I have a little update for you about that from the network point of view. So we are going to hope to honour all of our courses that are outstanding, and some of them will go virtual and some of the existing dates will stand even if we're still under lockdown. Some of those courses will be delivered virtually, so that's just an early heads up about training, and there'll be more of that later. Okay, next slide please. This is another reminder about the Futures collaboration platform. Some of you will have found that and joined it, but for those of you that haven't, there's a lot of really good information that gets uploaded onto there. There's also a perinatal section, but there's a lot of good stuff that comes through the mental health and learning disability cell as well that gets uploaded. So I would really encourage you all to join that. The amount of emails you get back from it can be a bit irritating, but you can change the settings just to get a weekly update. So you don't have to be bombarded with absolutely everything. So I would encourage you all to join that. There's also an IAPT section on it as well. Okay, next slide, please. I just wanted to give you the heads up with some resources, some new resources that came out last week. SANS and the Miscarriage Association have both put some new information on that's COVID related, and I thought it was really important to share that with you. And then on the right hand side of this slide is a really lovely thing about infant mental health, which I actually found on the Futures collaboration platform. But it's obviously far too small for you to see it at the moment, but I would absolutely recommend that people read that and share it with their teams, because it's a lovely, lovely piece of work about keeping the baby in mind with home visiting and virtual visiting as well. So I would really recommend everybody involved with perinatal services and the wider stakeholders to have a look at that one. I thought that one was delightful. Okay, next slide, please. And so this is just to remind you about Maternal Mental Health Awareness Week. Obviously, they've had to change a lot of what they had planned, but they're using a lot of social media to deliver their materials this time with a different topic every day. So lots on Twitter. There's also new things on their website and some really good stuff happening there. So that's just a reminder to check in and look at some of that's going on. And now I think that's the last of my slides. Can we just go on to the next one? Yes, so I'm going to hand over back to Liz now to talk through some other national updates.
Thank you, Jenny. So last week, Simon Stevens wrote to each of the trusts and NHS services in terms of the second stage of the NHS response to COVID-19. And all I've done here is just picked out some of the key highlights specifically for maternity and then also for mental health, just to go through really. So in terms of maternity, it highlighted that providers need to make direct and regular contact with all women receiving antenatal and postnatal care. explaining about accessing services for scheduled and unscheduled care, and emphasising the importance of sharing any concerns. So in line with the promotion of the KICS campaign and that, so making sure, particularly for fetal movements and that women do come forward if they have concerns. Also ensuring that obstetric units have appropriate staffing levels, included anaesthetic cover. And then in terms of screening and immunisations, the antenatal and newborn screening services must be maintained, bearing in mind that it's a time critical service. Next slide, please. And then for mental health, so for mental health, it was generic for mental health as opposed to being specific for the individual elements of mental health, but ensuring that existing patients known to services continue to be contacted proactively, particularly after recent discharge, or those that are shielding. Prepare for the possible long-term increase in demand as a consequence of the pandemic, and actively recruiting in line with the NHS long-term plan to existing services. Ensuring that there's enhanced psychological support available for NHS staff, and continue to take into account inequalities, particularly thinking about the needs of our BAME communities. And we've had discussions about that previously in webinars, and we hope to have further information about BAME communities also for future webinars as well. And then in terms of care, education and treatment reviews should continue, and obviously the continued use of online and digital approaches that we know that you've all been working really hard to get up and running over the since COVID started. Thank you. Next slide, please. And then hot off the press yesterday was an updated version of the key deliverables for the local maternity systems in 2020-21. And the highlighted in red, I appreciate you can't see this, but this will be sent out to you, and we will send out the full version separately as well, is obviously remaining on track to reduce 50% rate of stillbirth, neonatal death and maternal death and brain injury by 2025. So just highlighting that that is still a key target. The other deliverables on there are the ones that you have previously received that came out at the beginning of COVID, but we will send the full document out to you for your reading. Thank you very much. Next slide. So as Jenny mentioned at the beginning of the webinar, it was the International Day of the Midwife yesterday, hence we are wearing shades of yellow. And Abby Applin from the RCM, who kindly presented at the last webinar, has just shared a couple of slides with us. Next slide, please. So obviously the celebrations this year are slightly different to previous years because of the situation we're in, but ever, you know, as just as much relevant and important today. So there are various celebratory events going on online, also through Facebook, Instagram and Twitter. So do look out for all of that. There's a great version of Somewhere Over the Rainbow, which I think we'll share later with the link of a midwife singing across the country, which is very uplifting. And please share any stories that you have in terms of how your services have been celebrating as well. Next slide, please. There are also various different awards, so different to the normal award format that we would have been able to do if we weren't in lockdown, but giving thanks to a midwife, celebrating the online events, sharing what a midwife means to you, from a women's perspective, but also what it means from a midwife perspective. There's various things already online. We will share them, and likewise, as we said, please share them with us as well. Next slide. And further information, if you want to go onto the RCM website, you can be found there. Lovely. Okay, next slide, please. So I'm going to hand over and introduce Emma Taylor from Reading Maternity Voices, who is kindly here to give an overview of the feedback that they've received during the COVID-19 pandemic, and there'll also be a woman's story to share as well. So if I can hand over to Emma.
Hello everyone.
Thank you.
So yes, I've just put together an overview of the feedback that we've been receiving. So we cover Reading, Wokingham and West Berkshire, which is quite a diverse area. If I could have the next slide. So we've gathered feedback from women using our usual online survey. We've also been receiving a lot of feedback from women individually via our Facebook page, either sharing comments on posts that we've shared or contacting us directly through messaging. And we've also been working with local midwives to run weekly Q&A sessions on Facebook. And there have been a lot of questions coming in from that and a lot of worries. So I had a look and pulled together the main themes that we've been having in our area. Partners are the main issue, I think, at the moment for women. They're really concerned about when partners can actually come in and be with them. And particularly for caesarean births, women are anxious about at what point their partner can be with them. What happens if their partner's ill or symptomatic, and can they have an alternative? And just really wanting to know the details of when partners are able to come in, when they have to leave. Related to that is issues around scanning, with not being able to have a partner at the scans, wanting to have the sex written down if possible, so that they can share that moment with their partner rather than know in advance of their partner. These are the sort of things that are really big for women and families, and perhaps, you know, they're not clinical issues, but they're things that are really important to women and families all the time, but particularly right now. Another issue that's been coming up is anxiety around appointments, midwife appointments and GP appointments. Lots and lots of questions coming in saying, you know, I'm supposed to have an appointment in 2 weeks and I haven't heard. So although the procedure was that midwives were all getting in touch with women individually and confirming where and when their appointments were, women were having anxiety about that in advance of having received that call, which I think just reflects a general anxiety around COVID-19 and the lockdown, and everybody just generally feeling more anxious and wanting to be in control of what they can be in control of. So a lot of worries about that. And in our area, the GP appointments now aren't being done by GPs. The midwives are doing all of those appointments and have been for a couple of weeks now, because the GP surgeries just weren't able to manage that. But there's also been concern about a lack of face-to-face contact. Obviously, a lot less of the appointments are able to be face-to-face for obvious reasons, but women are finding that extremely hard, and they're anxious about their blood pressure, about their fundal height measurements, just all of those general checks. And more specifically about in the hospital, some anxieties around pool availability. In Royal Berkshire Hospital on delivery suite, we have our midwife-led unit is closed at the moment, so there is delivery suite and the home birth team running, and those are the options for women at the moment. And there is just one pool available on delivery suite because of logistics, and particularly now the logistics of needing to have the hot and cold areas. So there's been a lot of questions from women wanting to know if they can bring their own pools in, or if they can provide pools through fundraising, which isn't a possibility, but that seems to be quite a big theme. And again, I think that feeds into what women feel that they're able to control around their birth. They've been very accepting of a lot of the changes because we all understand that these changes have to happen. So there's more focus on the smaller things. And so the last one on that slide is when they can go home. Lots of questions about at what point they're able to go home. Some women wanting to stay in, some women wanting to go home as soon as possible. So just lots of questions around that. If I could have the next slide. Some other themes, that these were, the previous slide was the ones that were coming up much more often, but there were also questions from women about wondering, should they be wearing masks and gloves to appointments, because they're obviously worried about contracting the virus. Concerns about their antenatal care, again about the appointments, the detail, what to pack. Lots of people saying, what should I bring? How many days worth of things do I need to bring in? And just really wanting to understand the detail. There's been quite a theme for us about women reporting that their growth scans are being cancelled. My understanding is that that's postponing or that they should still be happening, but the questions have been coming in where women are perceiving that they're being cancelled. Questions about how they can make delivery suites more like the midwife-led unit, so a bit less medical. And again, I think that's about controlling small elements to help them manage their anxiety. And there was something very specific from a few women about appointment details for their caesarean birth pre-op. It came up from a few women, so not as big an issue as some of the other themes, but I don't know if this resonates in other areas for the sorts of things that women are thinking about. So I think it's just a reflection of general anxiety and just really wanting to know the details, that they really understand what's happening. And if I could have the next slide. So I say this is all causing anxiety, born from anxiety that's already existing because of the situation. And I just pulled together some ways that we found have helped, either in our area or things that I've heard from other areas as well, other MVPs. So good communications that you co-create with your MVP. One of the things that I've done is write together with our director of midwifery and a consultant a leaflet that was explaining some of the changes around the testing that's come in, where women will be offered testing, and just making that very woman-centred, easy to understand, changing the medical language. Small changes like that, if you co-create with your MVP, really makes a difference to the women, so that they have a full understanding of what's happening. And they've been very accepting of the changes if they understand. So say FAQ sessions on Facebook, the way we've been doing them, our midwives didn't want to be on video, which I completely understand. So we've been doing them just as a post on the hospital Facebook page. So I've been present via a phone link, and we've been working together on typing answers to questions that women type in under the post, and that's been massively well received, and women have really loved that ability to come in directly towards midwives, just ask a question and get an answer. Facebook live sessions, we haven't been doing these. I know Oxford have been doing lots of amazing Facebook live sessions with one of their midwives, similar thing, ask the midwife, or looking at a particular theme, and I know that they've been really well received. So where midwives are willing to go on camera and be live on Facebook, those have been great. We have an FAQ document that's hosted on the hospital website and is updated regularly after each FAQ and as and when anything new comes in from other sources, so that there's always an updated resource for women to access and to understand exactly what's happening. Regular information posts on Facebook through the MVP and through the hospital are also really useful for just updating women. And as I say, updating maternity information leaflets where that might be appropriate, where things have changed, so that if women are accessing existing leaflets, it's actually not the old information. And all of this is about really just alleviating women's anxiety. We understand that there's a lot of things that have to happen and can't be changed. But I think that these measures have really made a big difference, and women have been really, really pleased at how the midwives in our area have been, wanting to communicate with them, and it's been really well received.
So I'm delighted to introduce Liz Brutus, a public health consultant, who is going to give us a very quick whiz through the all-important issue, which we will be returning to, about BAME, COVID-19 and pregnancy. So thank you very much, Liz, and over to you.
Can't hear Liz.
Liz, can you make sure that you're not on mute? Have we definitely got Liz on the call already? Is Liz with us? Okay, I suggest if Liz isn't with us, she should be joining us. I know she had something first of all, that we move on to Dawn's slides, which is slide 27, Ryland. Jenny, shall I hand back to you a second?
Yeah, that's fine. So again, it gives me really great pleasure to introduce Dawn Brenchley, who is Specialist Health Visitor for Perinatal and Infant Mental Health. And in response to some earlier questions about people wanting to know different ways of working virtually with clients, Dawn has very quickly taken her face-to-face group to virtual. So over to you, Dawn, to tell us how you did it.
Thank you, Jenny. I hope you can hear me all right. Thanks for having the opportunity to share what we've been doing in Hampshire. And as you said, Jenny, earlier on, we're all learning together, aren't we? So we decided to take our face-to-face groups to a virtual setting about a month ago. We've been running groups face-to-face for Knowing Me, Knowing You for the last 4 years in Hampshire. And these groups, if you're not aware about them, if other people on the call are not aware of them, are facilitated peer support groups for women with that mild to moderate low mood anxiety. And we've worked in partnership with our IAP service, iTalk in Hampshire. So we decided to put together a new programme for the virtual setting. And this is just a summary of what we've been doing. So we normally operate the face-to-face groups on a 7-week programme. It normally ends with a bring and share lunch, but obviously we can't do that at the moment. So we're running a 6-week programme for women, and we're piloting 10 groups over the next 6 weeks. We launched our first groups last week. So we've run 5 groups so far. As I said, we've been working in partnership with our iTalk partners, and they've been really great actually with a can-do attitude, to get these up and running. As I mentioned, it's open to women with mild to moderate depression with or without anxiety in that perinatal period, and with babies under 1 year of age. All of those mums are assessed using PHQ-9, GAD-7 and Karitani parenting competence questionnaires like we would before a face-to-face group. And initially, we've opened the groups to those who were waiting for face-to-face Knowing You groups to start. So we had quite a few women who were due to start groups in April. So we've reached out to them first. But we're also, because we've opened up postnatal contacts again from our health visiting service, we're also then getting referrals in for the next groups that will start in around 8 weeks' time. Can I have my next slide, please? So how they operate is that we've got around 5 to 6 mothers in each virtual group. We normally have around 10 mums in a face-to-face group, but we really wanted to be able to see the mums and babies in these virtual groups. So we've reduced the amount of women in each group, and we hope that's going to help them really build that rapport with each other and us. And we normally run groups for 2 hours in each session per week, but we've reduced that to an hour for this pilot, mainly because it's very tiring, isn't it, listening to a virtual setting, and also when you've got a very young child with you. So we're trialing that for an hour to see how that goes. We've reviewed all the materials we normally use in a virtual setting, and reduced the content so that it's appropriate for a virtual group. One thing that's working really well, and we weren't sure how it would go, is that we've kept a nursery nurse element into the group. So around 10 minutes before the end of our group, we have a nursery nurse who runs an activity for mother and baby, and that's very simple, but it's really supporting bonding and attachment and getting that closeness between mother and baby. So it's something as simple as having a nursery rhyme song the first groups have run, and then later on building up activities, and that's working well. There's been a lot of debate about what technology to use, what platform to use, because we're all obviously very concerned that it should be safe. We are using Visionable group technology. We use this face-to-face already, and our iTalk partners already use that too. So we've been able to get a group license for running these groups through Visionable, and that's what we've launched with. Can I have my next slide, please? So this is the sorts of things that we are covering in each group. As I mentioned before, it is facilitated peer support. So this guides us through each week, but it can be flexed to what each of the group needs. But in week 1, we have a welcome session, really getting to know each other. Week 2, we look at baby states, or if they've got older children, particularly we focus on 5 to Thrive. And that's all about responding to babies, their emotional well-being, what they're communicating. And then in week 3, this is led by iTalk, which is looking at the triggers for emotional well-being and how to manage those triggers, how to identify them. And then week 4 is about relationships. We're quite conscious about this virtual setting when we discuss these, because we are aware that partners could be in the room. Week 5, we talk about wellness and mindfulness. And then week 6 is about moving forward and really learning about those next steps that people want to take and what further support they might need after the group. And then the next slide, please. So this is a real sort of capture of what we've learnt so far, because we've obviously only been running for just over a week. What we do is, with the Visionable group technology, we can send a survey monkey out after each group, and then we can sort of capture that feedback as we go. So we could swiftly change something, if it wasn't working. But what we've learnt is that groups are running well. Clients appreciate that we're trying to do something at this time. The peer support obviously remains the most important element that people like about the groups. Just knowing, it's not just you who's feeling like this at this time. I think that seems to be what's giving people the most satisfaction about the groups. And it takes time to build rapport in the groups, though, in a virtual way. And so we're really spending time helping people introduce themselves and their child, and sharing about how they are. And that does seem to take longer in a virtual setting. We obviously need to evaluate how this is experienced by our clients before we expand the programme. But we are aiming to scale this up to reach other parts of Hampshire, because the need is there, and we do want to make sure we provide support. And it's likely that we are going to have to continue in this way for some time, because it's unlikely we're going to be able to meet face to face for some time. But we are hoping that we will be able to get these groups together face to face at some point. And I think we were all worried about technical issues, whether this would let us down, but actually there have been few technical issues that would inhibit the groups. Everybody's been able to get onto the group. We've had a few issues with trying to get cameras to work and things like that, but on the whole, we've been able to iron those out. So far, so good, but we know we've got a lot to learn as we move forward. Thank you.
Thank you, Dawn. That's really helpful. We'll have, if you're okay, we'll just take a couple of questions now before we show the little film which we've managed to get running. So from the previous speaker. But yeah, if anybody's got questions for Dawn, we can take those now. I guess you'll be around for questions at the end as well, Dawn.
Yes, definitely. Yes.
Hi Dawn, it's Alison Wenstrup, one of the perinatal consultants. I'm just
Hello.
wondering if we want to get ladies perhaps who are not going to need our service but would benefit from yours, can we ask for them to get into the Knowing Me, Knowing You groups? How would we do that now?
Great, thank you, Alison. It's a really good question. So we have referrals into the health visiting team that is local for that woman. So I would recommend, if women would be interested in Hampshire to participate in the groups, then certainly get in touch with their named health visitor and discuss that. But if that's a problem, just do come to me. My details are on the first slide, so please let me know if you have interest, and we can put you in touch with the right facilitator of the groups.
Okay, thank you.
And there's a question in the chat box from Eleanor, Dawn, which is, do the groups continue privately between the mums when the sessions end? Have you gone far enough into the virtual groups to know if that's happening? Because I know that was a definite lovely spin-off from the face-to-face groups.
Absolutely. So what we normally do is we facilitate them setting up a WhatsApp group once we're into the group. So we're planning on putting that in place around week 3. We have boundaries and guidance and ground rules for how that works for mums, but that is continuing to happen. So we normally get that set up in week 3 for the virtual program. So some groups are in week 2 this week and they seem to be going well, so we're putting that in place next week. So then they can communicate like that, and then that generates that further peer support, doesn't it, as well?
Brilliant. Just a question from Darcy, which I'll make the last one at this time, Dawn, is how many usually attend the group, the virtual group?
That's a really good question as well. And it's around 5 to 6 women. We were worried that we might get quite a high attrition rate. Last week, one of the first groups met and there was only 2 in the group, but then we were able to get them back online this week. So there's now 4 in that group, and that seems to be working okay. We're looking at the numbers. We're thinking, should we open it up to 8 women, knowing that we might then get 5 to 6. But our facilitators of the groups are new to this setting, and we're keeping it quite small so that we can really see them and they can see each other. So we will look at that and see how many, but around 5 to 6 is what we're getting at the moment.
Thank you. I guess in these strange times, it's really important for people to feel that sense of connection, isn't it?
Yeah, definitely.
Okay, well, thank you so much, Dawn, and thank you for staying to the end for other questions that might come up.
Welcome.
I'll go back to the little film now from Maternity Voices.
There's a change. So I think Liz has to leave by 11. So actually we're going to do Liz first. Sorry to keep shuffling around. And then we'll go back to the video.
Okay, so over to Liz now, who, if we can get those slides up.
Which is slide 23, Ryland.
Thank you. So Liz Brutus, public health consultant, talking about this really important subject of BAME and COVID-19 and pregnancy. Thank you so much, Liz. Over to you.
Oh, good morning, everyone. And I'm going to turn off my video. So I'm not sure if my face shows, but I'm just going to turn it off to make sure that I can maintain my broadband link. So I'm sure we've all been slightly struggling with our various bits. So yes, I wanted to talk today just to raise the issue with yourselves about the emerging evidence and information that's coming out about the COVID-19 pandemic and the relationship with BAME and also COVID with pregnancy. And so I wanted to stress at this point, these are really kind of early thoughts and thinking. my role, how have I been involved in this? I'm the public health service lead for Slough Borough Council, and within the South East, it has been identified that Slough is certainly taking quite a hit from COVID. We've had a high number of cases, and we've seen that our death rate is emerging to being in the top 10 outside of London, unfortunately. In addition to my general role as a public health service in Slough Borough Council, I'm within the Frimley LMS, I'm the chair of the preconception and maternal health group. So it's kind of very much about keeping women well and getting them well for pregnancy and then keeping them well during it. So with that in mind, some early thoughts and thinking, and forgive me if some of it is basic and you know it already, but I just kind of wanted us to pull it together. So there is some emerging evidence that suggests that BAME women, BAME people, but particularly health and care staff, are at higher risk of poor health outcomes from COVID, whether that seems to be more frequent picking up of the infection, worse severity and death. And we see that this seems to be adding to the risks, which we know already, which particularly around age. So we see that COVID is far more common than its ill effects for people, particularly from about 45, 50 onwards. It's affecting males more than females, and it's particularly there for people who have underlying health conditions, and particularly where we see it, say, vascular heart disease, so angina and high blood pressure, diabetes and chronic lung conditions. So for many of our women, by the fact that they're female and that they're younger, that there's a degree of protection from that. And so with that in mind, we do see that on the whole at the moment, pregnant women do not appear to be more likely to be seriously unwell than any other healthier adult. So obviously pregnant women who do have underlying health conditions, we would be cautious, and I'm sure many of them will have received letters from either their GP or nationally around the shielding programme. One of the things, though, that we don't yet know, and I think it's really important perhaps just to flag it there, this is a difficult one, because on one level we're flagging a problem, but we don't yet really know if there's a definitive solution. But one of the things that we're seeing is, in general, BAME people have higher risks. But we're balancing that with, in general, pregnant women don't seem to be particularly at risk, even though pregnant women immune system is kind of, that there is kind of variation from their non-pregnant state. But what we're seeing is, in particular, Black Caribbean people have about 3 times the white British rate of death and severe illness. Bangladeshi people about twice the amount. Pakistani almost 3, sort of 2.9, and Black African similarly about 3 times the rate of white British people. So one might deduce that therefore a pregnant woman of those different groups may also be at greater risk. So I think in the absence of that, in the absence of really clear, definitive information about what to do next given this increasing risk, is really the importance of flagging the basics that we do know seem to be protecting people. And so it is kind of that reiteration, that emphasis, that explanation around the importance of both good infection prevention and the importance of generally staying well. And from an infection prevention, it's that social distancing, which we do know there are differences between the way that different BME groups have embraced or not embraced social distancing. And you don't need to be an epidemiologist to see that. We also recognise the importance of really good hand hygiene. So it's really important to stress that to pregnant women. I'm sure you're doing it already. And that catch it, bin it, kill it, sort of that old mantra that make sure that that people are using tissue and then disposing of it and so on. So there is that kind of the basics of infection prevention. And then one of the other things that we know is happening with COVID is that it's acting to kind of deter people from seeking help. Those who are well are thinking to themselves, there's no way I'm turning up to hospital and taking the risk, because I'm well now and I don't want to go somewhere where I fear that there'll be a greater problem. So it's that kind of that balance that I'm sure that you're already doing, and that is already happening, about the importance of maintaining really good and regular routine antenatal care. And just, from the sound of the last bit that I picked up, we are working imaginative, we are working creatively, we are using technology wherever possible, we are trying to reach our populations. So I think it's really important to stress the importance of that routine antenatal care, deliberately to kind of keep our women well. And then
I just interrupt, Ryland, could you just go to the next slide for Liz so that thank you.
Oh dear,
carry
gosh.
on, Liz. When you want your slides changed, if you just say next slide, it will move on for you.
Brilliant, thank you. Sorry about that, everyone. So yes, that kind of recap. I've talked about the risk. A risk in general for COVID. I've talked about the fact that at the moment it doesn't look that in general pregnant women are more seriously unwell, although, as I said, BAME people are emerging as having problems. But the importance of good infection prevention and then the staying well, which is recognising the importance of routine antenatal care. Protecting mental health, because obviously it's a really important time in a woman's life and in a family's life when a new baby is on the way, and protecting mental health. The importance also of maintaining physical well-being, whether that's ensuring good physical activity, healthy eating, and particularly if people are indoors a bit more, that recognition about the role of vitamin D because they're not getting it naturally in the sunshine, or perhaps not as much. And then those wider impacts that we've heard about, where families perhaps are suffering or anxious about money or about housing, and then the knock-on effects that we're seeing in domestic violence. So these are the things that we're kind of doing. On one level, you can say that these are the basics. So apologies if I'm teaching you to suck eggs on that one, but I just wanted to reiterate at least the basics while we work out if there's additional measures that we need to take on board. The next slide is I've pulled together some resources which may be helpful both as for professionals and for women, for us to pass them on. And this has been taken, Public Health England have been pulling together rapidly a health inequality toolkit, and these include some of these resources, so thank you very much for that. They pick up some pregnancy ones, particularly around health and wealth. So it's about the maternity rights and benefits during pregnancy and maternity. Some guidance about COVID and pregnancy. There's information about the Start for Life work. About supporting women to have a healthier pregnancy and those early days when the new baby arrives. And then a shameless plug for Frimley's local maternity system, because we have a new website and we also within that have a new parenting guide. There's additional information from the Race Equality Foundation, which provides information about for Black and about the connections between BAME and COVID, and that can be quite helpful to understand some of the challenges and issues. And then information in different languages, recognising that English is not necessarily the first language for many of the women that we see. I think one last thing that I'll almost finish on is that the NHS, when we think about staff who work for us or work with us, the NHS last week recognised that connection between BAME, higher risk for BAME people with COVID. And there is some further advice that's come out about risk assessment in the workplace. And so I'd urge workers who are pregnant and just workers in general, particularly who are BME, to make sure that they are having that good risk assessment for their workplaces. I work in local authority, and I know that we are also looking at that guidance and thinking what we can do for our social care staff, any frontline staff, but particularly social care staff, and also as commissioners of social care, what we can do for our care providers. So recognising obviously that interaction between COVID, ethnicity and pregnancy, recognising that we don't know it all yet, but this hopefully is a start. And then the final slide is a shameless plug for parenting guides, which hopefully in amongst all this provide some guidance for women from both bump, antenatal, all the way through to 19. And it's hopefully one less worry at this difficult time if people are juggling children at home and their own pregnancy. So I'll stop there. I'm very happy to take any questions, and I hope that was a little whistle-stop tour into what we know so far.
Liz, thank you so much. This is such a massive and pertinent issue, and so it's great that you've given us a taster, and it's something that we'll definitely be returning to. I think I'm right in thinking that you have to leave quite promptly, so that means you won't be able to stay for a Q&A at the end. So let's get any questions from the audience now. And also we need to move on to that last slide, please, of Liz's. That's the one, thank you. Yeah, if anyone's got any questions for Liz, do ask them now, because she can't stay until the end.
But I'd also just say I'm very happy that these slides be shared, recognising it can be quite difficult to see them on the screen unless you've got them up in front of you.
Brilliant, thank you.
Okay. Hello, is that, sorry, can you hear me? It's Paulette here from Surrey Heartlands. Hi, thank you for that. It's really, really helpful, because we have had some concerns. So from one of the areas that's got more of a BAME community, just really in terms of how we support staff, and it was great to hear about the risk assessment and the different resources. The issue was really around their workload and what they feel they can do, and also just from the perspective of the clinicians and not wanting to feel different, and that they're not also contributing to service provision. So I think it's just useful to have those extra resources just to, I suppose, support staff really in the work that they're doing, and I suppose just to reiterate that they're still valuable and still providing a good service and are instrumental within the teams as well. Because I think there's something about this information that's coming through that can also put another layer in of difference. And it's just how we look at that and just making sure we can still keep that positive culture in the workplace.
Yes, I'd agree with you. I think there is always the risk of stigma, isn't it, when we start separating people out, and certainly some early feedback from those who've been shielded, whether it's through the kind of the age cut-off or because of certain long-term conditions. There's definitely a sense of don't write me off. I do have useful things still to contribute. So I think that will always be the challenge in how that's done. And I think wherever possible, drawing on people's expertise through remote working, even if they can't deliver that kind of hands-on frontline care. I think we absolutely need to draw on our staff's expertise, whatever the risk factor that may be keeping them away from the front line.
Thank you.
Okay, well,
sorry, I was going to ask is Dr. Wenzel again. With the obviously identifying these more at-risk groups, but also now that we've we are supposedly going to get antibody testing as well. Is there any way that we're going to be able to make use of that to perhaps identify people who have actually been exposed and have resistance that may be in some of these more high-risk groups?
Yes, I mean, I think the antibody test is still a little way off in terms of its accuracy, and so and I'm not sure at a national level when that's going to be introduced. I'm sure that there will be a bit of a rollout, and it may be that Richie would deliberately it's deliberately rolled out in order, in a sort of segmented risk assessed sort of way. I guess the only other thing that we're sort of will need to just balance that with is whether proof of infection matches your ability to fight it if you're exposed a second time, if that makes sense. So obviously, if you had measles once, you won't, you're very unlikely to get it again. But we don't know enough yet about the coronavirus to tell us whether it gives us immunity to withstand other, future infections. So I think that will all be part of the testing, and to make sure we're not giving ourselves false security.
Okay, thank you so much, Liz. That's definitely something that we'll be returning to.
You're very welcome. I'm glad to be able to just inject this, and wish everyone well as we all sort of labour through this difficult time. So thanks, everyone.
Okay. We thought we'd resolved our technical difficulties with the film, but apparently not, sadly. So we will try and get back to that for another session. But in the meantime, I'm going to hand back to Liz, who's going to introduce our next speaker. Okay, thanks.
Thank you, Jenny. Yes, we'll make sure that video is shared, and if not, hopefully we will share it on the next webinar on the 20th of May. So if we could move to slide 31, Ryland. I'm going to introduce Andrea King to everybody. Andrea is the local authority advisor for children and young people's mental health, working with the Hampshire and Thames Valley Clinical Network. She has a wealth of experience and has kindly agreed to talk to us today about domestic abuse and safeguarding with regards to her local authority advisor role, and thinking about some of the work that they've done in CYP mental health and how we might apply it to perinatal mental health. So I'll hand over to Andrea now. Thank you for joining us, Andrea.
Thank you for having me, and my apologies, I've only just been able to join you. Colleagues, I was just asked if I could just provide a bit of an overview of what we're seeing in terms of the partnership pressures resulting from COVID-19. And then some of the direct applicability that could be of most relevance to you in the perinatal partnership offer. So I'll run through a few points. I'm mindful that we've circulated a summary of the particular areas of strategic pressure and operational pinch points that we suggest colleagues look at. And we have a question about, would that be potentially useful if we could adapt it for the perinatal workforce and leadership? So we'll touch on
Andy,
that
just
as we
to chip
go
in,
through.
so your paper hasn't been circulated yet, but we'll go out with the slides, just so that you know.
Brilliant. Thanks, Liz. All right. So just to provide a little bit of an overview of what we're seeing. From a local authority, from a criminal justice and a voluntary community face sector perspective, what we're recognising is a coordinated response to identifying and responding to vulnerable families, children, young people and the wider family unit. The key things to signpost to you all is that there are huge pressures on the front door, particularly of safeguarding services, and also those services where you're looking to triangulate and coordinate information sharing between statutory partners to build a picture of need and risk around children, young people and families. So we would describe that as the MASH front door or the triage functions that are normally shared between health economy, social care and the police particularly, but also education. In terms of child protection pressures, what we're picking up in our patch, so this is very specific to Bob, Frimley and the Hampshire Isle of Wight areas, are increases in non-accidental injury of children, and you'll appreciate that particularly tends to relate to small children, including those children who are not yet mobile. Now that's not everywhere, it's in some places and not all at this stage, but you will be seeing that increase both in A&E and then in the joint social care and police responses to that. Those areas where we've got what we would describe as an emotional health triage, so we've got health economy, we've got social care, we've got early help and education, looking at presenting emotional health needs for children and young people. That's in some of our areas, but not all. And in turn, then looking at parent-carer emotional health needs and saying, okay, so how systemically might we respond to this together, are benefiting at this time. So most of our areas have that function, but we don't yet have it everywhere, so that's worth being aware of. In terms of our criminal justice interface, police colleagues are very clear that the rise in domestic abuse incidences, will have all picked this up from the media as well as our individual services reporting information. Domestic abuse is rising fast. The level of injury and harm in those instances is higher in many instances than we're used to seeing. And one of the key things to be aware of here is that we're seeing households come through that have previously been unknown to statutory services. So this is new family units under pressure as a response to our circumstances and also some of those very real economic pressures that families are facing. So people out of work, huge insecurity around housing, etc. Unexpectedly, we've also seen a rise in exploitation. Now, from your perspective, my guess is this would particularly be relevant where you have young people entering into pregnancy. So understanding the context in which that pregnancy has arisen could be really important in a perinatal context. We weren't expecting to see that. We thought social distancing would reduce these kinds of forms of harm, so sexual exploitation and other forms of exploitation, but that hasn't been the case. For voluntary community and faith sector colleagues who are providing specialist mental health or family support services, everyone is reporting significant increase. Mind, Couth have released a series of reports on the nature of what level of need they are seeing and what the trigger factors for that are. You'll appreciate that for voluntary community and faith sector colleagues, this is also a time of funding uncertainty. So grant funding, fundraising through things like the marathons and all of those kinds of activities have caused some real funding issues for our wider partnership, and that's a context we need to be very mindful of. So those kind of close working relationships with our leaders in voluntary community and faith sector are particularly helpful. That wider context enables us to think about, so then where are we and how might we work together, and what are the things we might need to be saying to our operational managers and to our staff teams in terms of, please could you be particularly vigilant for these factors. So if we think about, for example, domestic abuse, and that's a core area that we'd want to be very vigilant to in all of our services, particularly in the perinatal stage, because of the potential increases in risk there. Being able to ask the open questions, but also having frameworks for the women that you're working with to be able to safely say to you, and quite often that's by the development of a code word. Things are difficult for me right now, so agreeing a code word via text, via email or in advance to be able to enable the women you're working with to signal to you things are not okay when they are in a space with somebody who may be posing them harm is crucial. And online systems for people to be able to signal and say they are struggling. So in updating our information, providing that kind of help is particularly useful for this, our relationships with women in this set of circumstances. Ryland, if we could move to the next slide. One of the things that we're particularly mindful of, and the operational and strategic summary that Liz will circulate on the back of this meeting picks out, is we understand that one of the unintended consequences of the lockdown has been a rise in emotional health need and mental health need, but it's a silent rise at the moment. So we expect that surge to follow post-lockdown, and we're particularly preparing for that kind of 6 to 9 month period, aren't we, of increased reports. We, in addition to domestic abuse and family conflict, which we've talked about, and non-accidental injury, and yes, I can provide some additional figures on that with the consent of those social care partners. We are also very aware of rising suicidal ideation. And so we have been watching very closely areas like Lancashire, which have seen a 40% rise in ideation, and also in partnership responses, including police call-outs. We are signposting, raising awareness resources which we can use locally in our communities to promote good mental health, but also to signpost very quickly where to go if you simply need to talk to somebody to try and respond to this rise. We're really mindful of the need for post-bereavement support, and that's particularly key for those families and friends who never got to say goodbye to the person that they love because of the circumstances in which we're needing to manage at the moment. Be particularly mindful in the perinatal stage of the impact for women who are already managing increased stress and the range of emotions that goes with that. But this is a particularly vulnerable time, so we're just encouraging a review of what have we got, how accessible is that, how well resourced are those supports. Within the update as well, there are some suggestions for the crucial role of supervision, and particularly reflective supervision for staff and volunteers. So some guides for operational supervising managers, which could be helpful to take into account the pressures for our own workforce at this time, and the space, the necessity of being able to say, this is where I am, this is what I'm seeing, this is what I'm trying to manage. Lastly, trauma-informed practice. We recognise that for our community at the moment, the rise in experience of trauma then is quite high. For those who have experienced previous trauma, being in a situation of this nature can evoke those memories really very strongly, and the associated responses that we may well have to cope and to try and manage. Within the guide, we've circulated the latest guidance from Anna Freud and other national partners on trauma-informed practice, and that potentially is one of the most helpful approaches we could be taking, both with adults and with children and families at this point in time, and as we move into recovery post-COVID. So Liz, I don't know if I stop there and say these are the kinds of things that we have been looking at. This is the information that we've been sharing and sharing best practice. If there are any questions and if there are any observations on how might we then be able to adapt some of this specifically for perinatal, if you think that might be helpful.
Thank you, Andrea. I think that's really helpful. Really good considerations and feed for thought. Do people have comments that they would like to share in terms of, as Andrea says, how we could adapt for perinatal mental health, or any additional thoughts in terms of things you are already doing? Please don't forget to unmute yourselves before you start talking. Any comments or questions for Andrea?
I can see that there's a question in the chat box about non-accidental injury for children, and I think you alluded to that in your talk, Andrea, but Charlie's asking, do you hold this data broken down into neonatal and peds?
So at the moment, we've got the overarching figures around non-accidental injury. What we are doing is opening dialogue with safeguarding partnerships, so the new MASA arrangements, to ask what the granular analysis is behind that. So with the consent of those partners, I think we could come back to you with further information where the systems are able to produce that, if that's helpful.
Fabulous. Yeah, that would be really great. Thank you. It's obviously at the moment with the LMS is paused, the level of ask that's okay to come from the LMS PMOs to the providers is quite low. So anywhere we can reduce the amount of questions and data we're asking for is really helpful. Thank you.
Hi. I was just going to mention, I work for the Berkshire Perinatal Mental Health team, and we have one of our safeguarding leads join a team meeting every week at the moment. Because we recognise that safeguarding issues are really, really high at the moment. So she's invited to every daily meeting, but she attends once a week in case that's helpful to other teams.
Hi. Another slight, sorry. Another softer thing. But I know, so I'm with a perinatal service. When we go out occasionally to see people with, you do come across families where none of the children obviously are going to school. They're sort of running riot, and there's a sort of, well, you know, we haven't got time for this schooling at home type business. So for weeks, these kids are just sort of doing their own thing. I don't really know how we can help in this situation.
Yeah, so I think that's really challenging. Firstly, Becky, well done. That's excellent practice, because looking out for the indicators of harm is crucial. Alison, yeah, that's certainly a challenge. It's a challenge we're working with schools in partnership at the moment. And there is a balance here between the hopes and aspirations for children and young people continuing to gain access to some of the curriculum, and a number of families saying we just simply can't manage the extra pressures associated with this. It is helpful to reflect on the fact that schools are being asked and directly encouraged to take more children falling in the wide vulnerable categories back into school. Within the context of safe management and distancing of those children. If you're worried about a household and you think it would be better for these children to be back in school, please reach out to the local authority in partnership with the family, and those children are likely to be offered a place to return sooner rather than later, which is a helpful support for those families.
Thank you, that's good to know.
Hi, this is Emma Taylor from Reading Maternity Voices Partnership. You mentioned about developing a code word with women to help them signal things are not okay. And I just wondered how you managed to do that, because obviously with some situations the partner may actually be accessing text messages and emails. And I just was interested in some ways that could work practically.
Yes, and it is case by case. Our domestic abuse services are particularly adept and skilled at this. And where you have concerns that mobile phones particularly are being monitored by a potential perpetrator or somebody who is perpetrating harm in a household, that wouldn't be a safe way to agree upon that code word. So if I can encourage you to have a look at the resources provided by domestic abuse specialist partners that set out a range of strategies, and see whether any of those strategies might work for the women that you are in relationship with. Please do. There's a whole suite of resources there which we can signpost to if that's helpful.
Yes, that would be helpful. Thank you.
Any further questions or comments for Andrea? Okay, lots of comments in the chat box thanking you, Andrea. I think it was really interesting, really informative. We'll share the paper with all the slides following this webinar, and any other resources that Andrea has to recommend as well. Thank you for your time, Andrea.
Thank you. Thanks for having me. Right,
so we're moving on So the next part of the agenda is really the collaboration session. So any questions for previous speakers? I appreciate we've lost Liz and that, or any general areas of discussion you would like to bring up in terms of ideas for future webinars, or anything else. Jenny, is there anything else that I've forgotten there that you would like to input?
There's just two things I wanted to highlight here. So the first one is that we're going to send out a survey monkey, just with, it's literally very, very brief, 4 questions, just to make sure we're on the right track with these sessions and that we can tailor them to exactly what's useful and helpful to you all. So that's the first thing. And the second thing is that the Perinatal National Team are putting on a webinar on domestic abuse and safeguarding on the 18th of May. So we'll be sending out the information about that, because that's open to everybody. And obviously that can go into a bit more detail. But I do still think it's something that we need to be considering on our agenda anyway in the future. So just those 2 things, really.
Thank you. Emma, you've got something you'd like to add that would have led on from the video, and apologies again, Emma, that we haven't been able to show that, but we will definitely show that at the next webinar. So Emma, if you want to come in now.
Yeah, it was just a brief comment that I wanted to make, that the story would have highlighted that despite all the anxieties and worries that women are having around their care, what we're hearing is that it's the individual relationships that they're then having with midwives and other staff that are making it a really positive experience. So although there's a lot of anxiety going into hospital, generally once they talking about afterwards, they're saying, you know, the staff were amazing, I felt really supported, I needn't have worried so much. That was a really common theme, that they felt they needn't have been so anxious. And I think that's A, an encouragement for all the staff doing amazing work out there, and B, something that's really good to try and communicate in some way to women, that it isn't, their fears are not necessarily completely justified, and that actually their experience won't necessarily be as awful as they're imagining in their heads at this time. But really just a shout out for the staff, because obviously the relationships make such a difference to women's experiences.
Thank you, Emma, that's really helpful. And please do, those of you that are on the webinar, please do feed that back to your teams, because I think that's really important to hear.
Yeah.
There's a question from Paulette in terms of staff wellbeing. Paulette, do you want to raise that?
Yes, thank you. So it was just a question really. So I was just wondering how staff are being supported generally in terms of their mental health and emotional well-being. I know that there's lots of information out there from the RCM, and various organisations are doing what they can to support staff in terms of, so there's some examples of virtual online support. The question I've got really is just sort of trying to look to see whether there's a resource pack that pulls everything together. And I've had that question really because in one of our areas, the head of midwifery was relaying to us in the CCG that there's been an increase in staff anxiety in the community. A lot of it was around home births and the issues around social distance, maintaining social distancing within a confined space, and sometimes people not being very truthful about being symptomatic with the COVID-19 symptoms. So I was just trying to look to see if there's any good examples out there in terms of how we can support staff further and just have it in one place. That was the plea that was coming in from the units. Yeah.
So there's loads of info that's coming out around staff wellbeing, and we'll pull everything together that we've got. I have to say, I would say it varies in its helpfulness. You know, some people have done some marvellous diagrams about theories of staff wellbeing, and I'm not convinced that's the most helpful thing right now. It's really about, you know, how teams have already come up with their own solutions to this. What's really working on the ground, and you know, I think for teams that are working remotely, some teams have found some fabulous fixes like regular check-ins. They've started team Facebook groups just to get that feeling of connection. And I think, you know, it's about good leadership as well, isn't it? It's about knowing your staff, knowing that it's not always the quiet ones that aren't okay, and it's not always the extroverts that are okay, and that sort of thing, leading from the front, being visible. So, but we will pull together everything we've got, and then I guess it's down to you guys to look at it for its usefulness. But what I think is the most important thing is that you keep telling us what's working or not in your setting, and then we can share that.
Thank you. That's really good. I think it's good for us just to share what's working well, and then we can learn from each other as well. And I think there's something about, at the moment, people are inundated with so many guidance, certainly within maternity, and I know other disciplines, so many guidance, so much information, lots of documentation, and it's just how we can make it practical as well, and just look at what works best. So thank you for that.
Yeah.
Hi, it's Pauline Bigwood here from Surrey. Sorry, I joined late from another meeting. So on both counts of those conversations, one, I've definitely found from our frontline teams in Health Team that exactly what you said, people have chosen either a WhatsApp group or particularly the Microsoft Teams end of the day or beginning of the day regular catch-up meetings to join together and talk through issues has been, really positive. The other thing I'm doing this week is virtual preceptorship with our newly qualified staff. I don't know what people have been doing about that, but I'm very aware of our newly qualified health visitors and ensuring that their preceptorship continues. And they've been very grateful to have that. So it's just a different group of people that to be aware of as well, that need that additional support. Away from the sort of team support groups, and then and also the looking at relationships, and you were saying about relationships with parents, and absolutely that continuity, and within health visiting, looking at how we've moved forward within COVID, the having that health visitor telephone, virtual, attend anywhere contact, and we've enhanced that contact by ensuring that parents have our work mobile numbers to come back to us, and also that we offer a 3 to 4 week contact as well now for every parent, so they get the new birth, the 3 to 4 week, and the 6 to 8 week contact as a routine for everybody.
Lovely, thank you for that, Pauline.
Okay, thank you. I'm afraid we've got 2 minutes to go, and keen to finish on time because I know people will have other things to get on to. Ryland, could you just share the link again in the message box, so it's right at the bottom, for the Survey Monkey? This is just, as Jenny said, a couple of questions asking you in terms of what you your thoughts and how we can improve these webinars. We will also send it out to those that have already had to leave the conversation. We'll send it out separately in an email so that you can access it either way. Please do give us your feedback. These are your webinars, so we want to make them as pertinent to you as possible.
And do feel free to forward the invites to other people that you think could benefit from them, because we want to be as helpful as possible in these difficult times.
Lovely. Ryland, could we just have slide 35 a minute? Next one after that. Thank you. So just to remind you, the slides will be sent out after the webinar, as will the recordings. And if you were forwarded this invitation, please get in touch with us on that email address, and we will make sure that you get invited directly next time. Thank you for your time, everybody. Jenny, is there any last words you would like to say?
No, just thank you for all your hard work, and do get the message out to teams that, everybody is really appreciating all the frontline staff, everything that you're doing. So, yeah, massive thank you.
Yeah, lovely. Thank you. We look forward to seeing you in 2 weeks' time on the 20th of May. Take care.